Hello everybody and welcome back to my channel. In today's video we're going to talk about calcium channels blockers, and I chose to talk about this because we use them every single day in our current practice, whether you are anesthesia provider, registered nurse, or any clinician have or will use calcium channel blockers at one point. So I have a framework here. We're going to talk about the classification, the mechanism of action, the clinical uses, the complication, consideration, and interaction. So before we even begin, I'm going to say calcium channels blocker can be subdivided into 3 groups, but they have the main mechanism of action that I'm going to share with you guys, and they have some common side effect. So I'm going to start by talking about what is common to all of them, and then we can dive into the different classification. So what is common to the calcium channels blocker is their mechanism of action. So in general, their mechanism of action consists of blocking the calcium channel, like the name says. So, but they're gonna block to the specific alpha-1 subunit, and they're gonna block only the L type. We have different type of voltage gated calcium channel, so they're only gonna block on the L type. So I'm gonna write it down. Calcium channel blocker, they bind to the alpha-1 subunit to blocking the L type voltage gated calcium channel. So this is where all of them are gonna act on the alpha-1 subunit. And also I talked about the side effect. All of them have common side effect, and when we talk about the specificity of each of them, I'm gonna show you which one has which one the more or less. So the calcium channels blocker, all of them are gonna give you headache, they're gonna give you flushing, they're gonna give you peripheral edema. Like if you have a patient chronically taking a calcium channel blocker, the patient is gonna have edema. They're also gonna give you gingival hyperplasia and flushing, dizziness, muscle weakness. These are all side effects of calcium channel blocker, and also constipation, right? They decrease your gastric emptying time, so they're gonna give you constipation as well. Now let's talk about the 3 classes of the calcium channels blocker. So I'm gonna divide them here into 3 classes. So here we have the alkylamine class, phenyl alkylamine class. Here we have the benzodiazepine, and here we have the 1,4-dihydropyridine. So these are 3 different classes, and why are they subdivided into 3 different classes? Because they act differently, right? They act, even though they have the same mechanism of action, they have some specificity while blocking the calcium channels. So here under that class, we only have 1 prototype, which is verapamil. And here we only have 1, which is diltiazem. And here we have all the ions. We have ifredipine, nimodipine, nicardipine, and clobazepine. So now let's see how they block differently the voltage gated L-type calcium channel. So if we have our cell here and we have our voltage gated channel here, let's talk about the verapamil. The verapamil is going to act here on the intracellular pole, and it's going to block the influx of calcium inside the cell. Now remember, for muscle contraction to occur, you need to have an accumulation of calcium inside your cell. So they're going to block the influx of calcium inside the cell right here. And for them to be able to do that, the channel has to be open here. So this is why they require the channel to be open in order to work. Now let's look at the lutetium. We still have our cell here. We have our transmembrane voltage gated sodium channel. The lutetium is going to act here on the inner surface here. Now, book says that their mechanism is really unclear, but we think that they act over here. And for them to be able to act here, they also need this channel to be open. So just like the verapamil. Now, let's see where the dihydropyridine works. So we have our cell here, and we still have our transmembrane voltage gated. The dihydropyridine are going to act here on the outer surface right here. So because they act here, even if the channel is closed, they're still going to be able to inhibit the entry of calcium because they act right at the top, so they don't need the calcium to be open. So because these verapamil and diltiazem are not dihydropyridine, we can call them the non-dihydropyridine. So the non-dihydropyridine are going to have this property of use dependency, frequency dependent, because the more the channel is open, the more they can block the entry of calcium. So they actually need that channel to be open, and they can block that entry. So they have this use frequency dependency. And if you have a patient that has a heart rate of 150 versus a patient that have a heart rate of 120, they're gonna act mostly on the patient that has a heart rate of 150, because in that patient, these channels are opening all the time so the calcium can get in. And because this non-dihydropyridine works better when the calcium is open all the time, so they're going to work better with higher heart rate versus heart rate that are a little bit less than higher. And this is the property that they have. Now, verapamil and diltiazem also have other property that the non-dihydropyridine don't have. Let's talk about verapamil. Verapamil is a non-dihydropyridine because we saw where the dihydropyridine works and their group. So these are considered non-dihydropyridine. Verapamil also have local anesthetic property. Actually, it comes in a racemic mixture, and his other D-enantiomer can block the fast channel sodium, given its local anesthetic property. And it's also alpha-1 antagonist. Yes, it has an alpha-1 antagonist property, making him more vasodilator than diltiazem. So diltiazem is also gonna be considered non-dihydropyridine and also have local anesthetic property, not just the alpha-1. And both of these non-dihydropyridines are going to act on different parts of our body. So let's see how they act. So they're going to act on smooth arterial, smooth muscle. They're going to act on the cardiac muscle. They're going to act on the SA node. They're going to act on the AV node. Now I'm going to put the AV node in red because this is where they love acting, on the AV node. So on the arterial smooth muscle, they don't really like arterial smooth muscle. Their preferential site is the AV node. So they're going to have a slight vasodilating property. So they're going to vasodilate. But we're going to see more vasodilation with verapamil than diltiazem. Remember, verapamil also have alpha-1 negative property. So vasodilate arterial vessel. Now, on the cardiac muscle cell, if you haven't watched my video about the action potential of the cardiac cells, please, I highly recommend that you watch that. But I'm going to try to explain it right quick here. So on the cardiac cell, we have, this is our action potential right here on the cardiac cell. And this is our phase 4, 0, 1, 2, 3. So they're going to act here on the phase 2, just like the beta blockers. So they're going to act here and they're going to decrease the entry of calcium. Remember, on the plateau phase, which is the phase 2, we have entry of calcium and potassium exit, which give us that plateau. So on the cardiac muscle cell acting on phase 2 here, they're going to decrease the contractility of the heart. So they're going to decrease the contractility. Now let's talk about SA node. So in the nodal cell, this is the action potential of the nodal cell. Something like that. So this is phase 4. Once we reach the threshold, we have phase 0 and phase 3 right here. So on the SA node, they're going to act on phase 4 and phase 0. So they're going to decrease the slope here, making it less likely to reach the threshold. So this is what they're going to do. So they're going to decrease the slope of spontaneous depolarization here. Decrease slope of spontaneous depolarization. And they're also going to decrease phase 0. Remember, after we reach the threshold here in -45, we have a depolarization of the nodal cell in the phase 0. So they're also going to decrease the depolarization phase 0. So how does this reflect clinically? So they're going to decrease the automaticity of the heart. Remember, the SA node is the natural pacemaker. So they're going to decrease the automaticity and decrease the production of electrical impulses in the SA node. And their preferential side, the AV node, they're going to slow the conduction velocity. So they're going to decrease conduction velocity, and they're going to increase the refractory period, increase the functional refractory period. Remember, the refractory period is when the heart is resting. So if they increase it, it gives more time of the heart to relax. So all these different side of action, because of all this, they're going to be negative inotrope, negative conotrope, negative dromotrope. And because they're going to vasodilate, they're going to also vasodilate the coronary vessel in the heart, increasing oxygen supply in the heart and decreasing oxygen demand. This is why these are great drugs for angina. So we are still talking about the non-dihydropyridine. So this is how they act on the body. Now let's see their clinical use. So because they're gonna, like I said, increase the oxygen level in the heart and decrease the oxygen requirement of the heart, they're gonna be used in angina. They're also gonna be used in hypertension because the vasodilate. We're also gonna use in maternal and fetal tachyarrhythmia, because these drugs are also going to act on the heart, decreasing the heart rate, but you just have to use them with cautious because they can decrease the uterine blood flow. And also, one of their main use is going to be on the supraventricular tachycardia. So on the supraventricular tachycardia, you can divide them into paroxysmal, supraventricular, and AFib, A-flutter. So in these patients with paroxysmal supraventricular tachycardia, these are great drugs because they're actually going to convert this rhythm into sinus rhythm. But when it comes to AFib and A-flutter, they're going to control the ventricular response of the rhythm. They are not going to convert, but they are going to control the ventricular response of the rhythm. So this is why if you have a patient who has AFib or A-flutter and also has a accessory bypass tract, just like in Wolff Parkinson syndrome, you don't want to give calcium channels blocker, because the fact that this is going to decrease the heart rate is going to have an increased effect in the bypass mechanism in the accessory tract, which is going to increase the sympathetic nervous system, and you're probably going to end up with AFib. So if your patient has AFib and A-flutter and have Wolff Parkinson syndrome, don't give calcium channels blockers. So we're also going to give them in cardiac hypertrophic myopathy, hypertrophic cardiomyopathy. So normally in cardiopathic, in hypertrophic cardiac myopathy, the ventricular is very thick, so it loses its compliance, and you have decreased end-diastolic volume because it can't stretch to get this volume. So you have decrease in your end-diastolic volume, but you also have increase in diastolic filling pressure. And these two actions are going to lead to decrease in your cardiac output. Now you can say, why are we going to give a drug that actually decrease cardiac output to this to hypertrophic cardiopathic myopathy? Because when you have a decrease in cardiac output here, it's more accentuated during like exercise, everything that raises your heart rate, like in tachycardia, because in tachycardia you have less time to fill up your ventricle and you already have a decrease in diastolic volume. So they are given to maintain that heart rate, especially when you are doing an exercise, so you don't get further decrease in your cardiac output. So these are also great drugs for that. And also, of course, we can give them in hypertension. So that was the clinical use. The adverse effect, we're going to have hypertension. Remember, they act on the vessel as at the lesser extent. They vasodilate, they're going to give us hypertension, they're going to give us all the side effects that are common with calcium channel blocker. But verapamil is going to give us more hypertension than diltiazem. Remember his alpha-1 negative property that he has. So we also going to have bradycardia, because it's going to slow the heart rate, right? It's going to act directly on the heart, slow the contractility, slow the heart rate, and this is going to be prominent with verapamil than diltiazem. So in elderly population, we rather give diltiazem because it's less potent than verapamil at doing this adverse effect. So we also going to have prolonged PR interval. Remember, it slows the conduction velocity in the AV node preferentially. So it's going to increase our PR interval. And we also have general side effect that I spoke earlier about. Now, the consideration and interaction, you don't want to give the non-dihydropyridine with patient that has systolic, severe systolic blood pressure. Because severe systolic heart failure, I'm sorry guys, because in severe systolic heart failure you have decrease in your ejection fraction, and these drugs are negative coronal and dromotrope, so they're going to further the increase of your systolic dysfunction. So you don't want to give it to those patients, so just be careful. And also special consideration, these drugs are going to have lots of interactions. So I'm just going to list some of them here. So they're going to have interaction with local anesthetic, neuromuscular blockers, inhale anesthetic. They're going to have interaction with beta blocker, digoxin, interaction with dantrolene, they're gonna interaction with diazepam, cimetidine / midazolam here / ranitidine. So let's talk about the interaction with local anesthetic. Because they have local anesthetic property, they're going to increase the effect of local anesthetic and give you more margin for toxicity. So just watch out for that. For neuromuscular blocker, they're going to accentuate the effect of neuromuscular blocker and also of opioids. So you just want to make sure that you decrease the dose of either them of your neuromuscular blocker. With the inhaled anesthetic, because they decrease the contractility, they're going to have profound effect, like profound cardiovascular depression with your inhaled anesthetic. So watch out. With the beta blocker and digoxin, these drugs also slow the heart rate, so you don't want to give them together at the same time. Dantrolene is a muscle relaxant that we give when a patient have malignant hyperthermia. So with the dantrolene, it's going to give you hyperkalemia and cardiovascular collapse. So just be aware. With the diazepam, they're going to increase the sedative effect of diazepam. And with the midazolam is going to mostly interact with diltiazem, and it's going to increase the sedative effect of midazolam. And also, midazolam is a high protein binding drug, and diltiazem as well. So they're going to interact, and one is going to have to get out of the protein and be unbound and increase the toxicity. It could be diltiazem, it could be midazolam. With the cimetidine, because these non-dihydropyridine are CYP450 inhibitor, So they tend to increase the action of medicine in the body because they decrease their metabolism. So cimetidine is also a CYP450 inhibitor. So it's also going to either increase the duration of action, or they're going to increase the duration of action of cimetidine. It can go both ways. Ranitidine is a drug. It's also a H2 blocker that decreases the flow in the hepatic flow, and it's going to decrease the metabolism of verapamil and diltiazem, increasing their blood level because they are highly protein bound, so they depend on hepatic flow to be metabolized. So these are some of the interaction, and this is just a global overview of how the non-dihydropyridine works. If you need, I highly suggest that you go for more information, but for the purpose of this video, I was just targeting on the main point. Now let's talk about the dihydropyridine. So we already see how they work. I'm going to touch base on any class and just give you the main point to remember. So nifedipine comes in 3 dosage types. You have the sublingual, the immediate release, and the extended release. In clinical practice, never give the sublingual and the immediate release because these drugs, those forms, sublingual and immediate release, are going to give you ischemia. They're going to give you profound ischemia of your heart, of your renal vessel. And because the dihydropyridine can also cross the CNS, they're also going to give you some brain infarct. So you never want to give nifedipine sublingual or immediate release, but you can give extended release. That's fine. So nifedipine is also going to be used for hypertension, but because of this side effect, people kind of go away from it. And also nifedipine, the general side effect of calcium channel blocker that I mentioned at the beginning of the video, you're going to find them more with nifedipine. All this gingival hyperplasia, hypertension, flushing, headache, dizziness, skeletal muscle weakness, you're going to find them more with nifedipine. So because of that, people don't really use that drug. Nimodipine, like I said, the dihydropyridine can cross the blood-brain barrier, and nimodipine has a acute affinity with the cerebral arteries vessel. It mainly acts there. So if you see ever nimodipine is administered, is for the brain. So most of the time we give nimodipine with the patient who has subdural arachnoid from like bleed in the brain, because we want to kind of contain and prevent or stop the vasospasm going on. And nimodipine has to be given over a period of 21 days. And it can also be given per orally or either NG tube or gastric tube. You can never give nimodipine through the vein. So nimodipine 21 days straight. So you cannot stop the treatment. So for that reason, if your patient is on nimodipine, even if the patient is going to the OR, you have to give the nimodipine that day. You have to find a way for them to get their nimodipine. So this is something special about nimodipine. Nicardipine is also a dihydropyridine, but it's special because it's the one that causes most vasodilation of all calcium channels blocker. Yes, and because it causes vasodilation so greatly, you want to be cautious when you use with patients that have severe aortic stenosis, because patients with severe aortic stenosis. So they depend on the preload. They are preload dependent and they are afterload fixed. So preload dependent because the aortic is restricted, so the blood from the ventricle cannot go out. So they already have a lesser cardiac output. So if you decrease again their cardiac output, they are not going to pump even the minimum they can pump out. Now, they are afterload fixed because sometime with some heart failure, if you decrease the afterload, the force against which the ventricle has to pump, it improves the ventricular function. But it's not the case with severe aortic stenosis. Because they are afterload fixed, even if you decrease the afterload like nicardipine can do greatly, it's not going to improve their cardiac function. It's not going to be improving their cardiac output. And they also need that little bit of afterload because they are used, their cardiac cell goes through a lot of remodulation and hypertrophy, so they are used to that bare minimum of pressure. So if you decrease everything, systemic vascular resistance with nicardipine, it's not good for severe aortic stenosis. And also, you would think that with nicardipine, you're gonna have great hypertension as a side effect because it's a great vasodilator, but actually you have more headaches than hypertension. Something that I find it was special. Now let's talk about clofazimine. Clofazimine is very, very fast acting. It's ultra fast acting, onset and offset very fast, and it's easily titrable. It only comes in IV, and this is your drug when you have hypertension crisis and you can't use anything orally. You can give clofazimine. So this is a great drug, and it's also its half-life is like 1 minute, so it's very fast because it's metabolized by a lot of esterases that we found in the body. So it does a great job at it. With clofazimine also, you can have rebound hypertension if you use that like chronically. You can have rebound hypertension, so you want to be aware of that. Clofazimine looks like propofol because it comes in like fatty emulsion. That's how it's administered. So if you have a patient that have disease of their lipid profile, like acute pancreatitis with hyperlipidemia or familial hyperlipidemia, you don't want to give clofazimine. Also, clofazimine is going to increase your triglyceride level. And if a patient also has soy allergy or soy-derived product allergy or egg-derived product allergy, you don't want to give clofazimine because it has a compound of those soy or egg inside. So this is also with patients that have pseudocholinesterase deficiency. So the pseudocholinesterase enzyme is the enzyme that is actually involved in the metabolism of your non-depolarizing drug like mevacurinium. If the patient has that disease, you don't want to give clofazimine because it's going to increase the toxicity of clofazimine. So just be aware of that. One thing I haven't mentioned comparing the dihydropyridine and the non-dihydropyridine is that because the non-dihydropyridine mostly act on the heart and to a lesser extent on the arterial smooth muscle, so with them you are not gonna have a reflex tachy. You're gonna have a bradycardia because they like the AV node. They slow the conduction velocity and they increase the functional refractory period. But with the dihydropyridine, because they love the blood vessel, right? They love the blood vessel. They act on the blood vessel and to a lesser extent on the heart. but this is just in isolated cell in experiment, but mostly focus on the blood vessel, and they can cause the blood-brain barrier. Because they dilate the blood vessel, you're gonna have a reflex tachycardia. You're never gonna have bradycardia with them. So this is the reason why you can give them in systolic blood pressure, in systolic heart failure. I don't know why I keep saying that. So the dihydropyridine can be given in systolic heart failure, but the non-dihydropyridine cannot be given in systolic heart failure, because you have this property in the AV node that decreases the conduction velocity and increases the functional refractory period. So it's going to worsen the disease. So guys, this was a slow pace subject, and I hope you guys enjoy it. Please, if you liked it, press the like button, share and subscribe, or leave a comment below if you want to see my other videos, or if you have any particular topic you want to talk about. Please leave a comment down below. I will see you guys on my next video. Thank you.